Good morning, everyone. This is Sherri White, and you're joined with me with my colleagues, Jana Eller, Ivan Berkel, and Addie Fauner. This is part 6 of our 8 series webinar, and today we're focusing on coordinated care milestones 8, 9, and 10 for primary specialties. For specialties practices, and 11, 12, 13, and 14 for primary care practices. So as you know, each of the different assessments that we have, there's 22 questions when we're speaking with our specialty practice, and there's 27 milestones for our primary care practices. Each score on the milestones determine the phase that you complete. For example, to complete a phase 1, a score of a 3 is necessary to complete milestone 13, which is setting an aim. Other phases require various scores for other milestones. Okay, just an overview. We have completed 5 sessions. They're all recorded and are available on the VCSQI.org website. And again, today is coordinated care, milestones 8, 9, and 10 for specialty, and 11, 12, 13, and 14 for our primary care practice. So today's objective is to review the scoring for coordinated care related milestones. We're going to outline strategies to meet each of these milestones, review the relevance of milestone scores to the phases, and then we'll have a little bit of Q&A session at the end. Okay, so this is just a recap of the specialty milestones the milestones associated with the specialty and primary care milestones or assessment. And again, we're going to always refer to change drivers, and these change drivers are located in your practice plan. Pictured here is the tab that you can find, which is the practice plan tab. And in column H is the links or the reference code related to the specific change packet. Jana, would you mind muting everybody's line for me? Thank you. Okay. So again, our change drivers or any associated change drivers relevant to the milestones can be found in column H of your practice plan or at the bottom of the entire practice plan file under the location or tab that is labeled change package. So related to our specialty milestones, we have milestone number 8, which is the practice facilitate referrals to appropriate community resources, including community organizations and agencies, as well as direct care providers. This is also milestone 11 for our primary care practices. We are also going to review milestone number 9. The practice works with primary care practices in this neighborhood to develop criteria for referrals for episodic care, co-management, and transfer of care or return to primary care, processes for care transition, including communication with patients and family. Also, we're going to focus on milestone number 10 for our specialty practices, which is the practice identifies the primary care provider or care team of each patient seen where there is a primary care provider and communicates to the team after each visit or encounter. So first we're going to focus on milestone number 8, which again is milestone number 11 for our primary care practices. And again, it states that the practices facilitate referrals to appropriate community resources, including organizations and agencies, as well as direct care providers. A score of a 3 is needed to complete phase 4. So as usual, we have our score assignments, where 0 is that the practice regularly refer patients to available community centers. Scaling up to a 3, which is needed to complete this milestone, which states the practice has completed its resource inventory and consistently links patients with appropriate community resources and follow up on referrals made. In between, we have a 1 and a 2, which has a different variation of completion between not having anything in place to completely meeting or demonstrating that your practice have this in place. All right, so strategies for completing this milestone. So we're going to refer to change packet 1.4.4. Examples would be to vet all potential referral providers and agency, leverage personal relationships to cultivate referral opportunities, maintain an inventory of community resources that may be available to patients, and this would be compiling a list and making sure it's available to all of your team members. Work with community agencies to enhance services available to patients. So this would be reaching out to local Weight Watchers or physical therapy programs, and just having a relationship and working with that environment to help create patient-focused services. Maintain a formal referral, links to the community. Let me start this over. Maintain formal links to community-based chronic disease self-management support programs, exercise programs, and other wellness resources with the potential for bi-directional flow of information. So that's information going back and forth. So for this one, consider the types of community resources that are relevant to the patients that you see. This could be the American Diabetic Association, Weight Watchers, physical therapy, local site centers for the blind, wellness centers, support programs, and perhaps pop into that organization to see what they offer and just make yourself known, or write a letter to each agency to introduce your practice and request information back, for example, brochures or pamphlets about their agency and services. From there, you can provide patients with contact information for those agencies and that are relevant to their needs, or just hand out particular brochures. And that speaks to the last, the last strategy on this slide, which is to provide a guide to available community resources. Okay, and change packet 1.4.4 is pretty lengthy. Here's some other strategies that you can tackle to achieve this specific milestone. Ask the provider, employ the philosophy. You should refer patients, or you should refer to a provider you would send your loved ones to. So understanding the processes that the practice that you, or the organization you may refer the patient to, becoming familiar with what they do, and then making that decision. Is this some place that I will send my husband or my wife to? And that, based off that judgment, you make that referral. Create and maintain a referral list for medical residents in academic settings. Engage local health coalitions to identify resources in the area that are scarce. Find out how patients define quality of care and build those definitions into the practice model. And also, we can maintain a referral tracking system to assure loop closure. And therefore, you make a referral, you want to see what's going on. Either they send a report back to you, or you can speak through the patient to find out what is going on with that referral. So just closing the loop. Ivan, before I proceed on to milestone number 9, is there anything you want to add on to this milestone?
No, I thought that was a good overview, Sherri. Thank you.
No problem, thank you. Okay, so let's dive into milestone number 9 for specialty practice. The practice works with primary care practices in its medical neighborhood to develop criteria for referrals and episodic care, co-management, and transfer or return to primary care. Process for care transition, including communications with patient and family. A score of a 3 is needed to complete phase 4. So here's the regular scale we have. A 0 means that there is typically nothing in place. The practice has, or in this instance, the practice has developed its criteria for appropriate referrals, but has not discussed these with primary care providers in the medical neighborhood. A 3, which is what is needed to proceed to phase 4, or to complete phase 4, the practice has collaborated with the primary care practices in its medical neighborhood and has jointly developed and implemented criteria for referrals for episodic care, co-management, and transfer of care or return to primary care. Processes for transition, including communication with patients and family, and always in between there's some modifications or renditions of criteria somewhere in between the 2, 0, or 3. So proceeding on, strategies to meet milestone number 9. In this regard, we're going to refer to Change Packet 1.5.2. Define the medical neighborhood with which the practice works closely with. Develop a personal and electronic relationships along the medical neighborhood providers to ensure information sharing. Develop formal written agreements or compacts to define information needs for all parties. Formalize the lines of communication with local care settings in which empanelment patients receive care to ensure documented flow of information and clear transition in care. Ensure that there is useful information that is shared with patients and family at the care transition. Partner with patients and family in developing processes and tools to make this happen. Engage payer disease management and complex care management staff to help avoid patient and family confusion. So a few examples that I will dive a little bit deeper into. We will share this presentation with you so you can have these links available. But through the advisory board, there are some tools or tips as it relates to building your medical neighborhood. And this is a nice resource as it relates to how to explore the opportunities within your neighborhood and the steps to cultivate that relationship for the focus of patient care. The next slide, or the next example, is crossing the communication chasm. I haven't had my coffee this morning. But this is a resource as it relates to how to reach out to more physicians and cultivate the relationships there. The website is very detailed also through the advisory board. And it gives you a lot of strategies and tools and tips as it relates to reaching out and cultivating a relationship with physicians. Okay, so for milestone number 10, and the milestone for this states that the practice identifies the primary care provider or care team of each patient seen, and where there is a primary care provider, communicates to the team about each visit and encounter. And forgive me for scrolling back and forth, that description was not included in the slide. So for this scoring, a score of a 0 would mean that the practice does not ask about the primary care provider. And it scales up to a 3, where the practice has a reliable system in place to identify the primary care provider of each patient and to communicate with each primary care team about each visit or encounter. And always in between, there's a 1 and 2 that are different variations between nothing in place and achieving the milestone. So in this regard, let's talk about a couple of different ways or different strategies we can do this. There's no specific strategies in the change pack for this milestone, perhaps because it is rather straightforward issue to resolve. So a few example is to add, who is your primary care provider, or PCP, question to the appointment information form that patients complete during intake. Train your staff who conduct intake interviews to document the PCP in the medical record. So in your check-in process, you should verify always the demographics, the insurance information, but also verify if the patient has a PCP and document it in an EMR. Add the PCP's phone number, email, or fax number to the patient's records. So this will be a good resource or place where you can always go to ensure you have an updated contact information, specifically fax number, for when you want to communicate the office note or send the office note to the primary care physician. In most cases, if your email is not secure, faxing medical records or the the office note to the PCP is the more appropriate way to go. Establish a process for updating PCP after each patient visit. So at the checkout process, check with the patient, hey, do you have any PCPs, or is this your current PCP, and should we add them to your medical record? And just make sure it's okay. Keep the information consistent and accurate with this milestone is asking. So we are now going to dive into the milestones for our primary care practices, and I'm going to hand this over to my colleague, Ivan Berkel. Ivan.
All right, thank you, Sherri. So the first three milestones we talked about, 8, 9, and 10, talk about how the specialty practices included primary care and other practices within their medical neighborhood. The next few milestones we're going to discuss are specific to primary care and speak to the extent to which primary care practices work to identify, establish, and communicate within their own medical neighborhoods. So for the primary care practices, there are 4 milestones. We've covered number milestone already. That was covered when Sherri discussed milestone 8. Number milestones 12 and 13 in the next few slides. Milestone 12 talks about the extent to which the practice has identified its medical neighborhood and has a formal agreement, either verbal or written agreements in place with these practices to define roles and expectations. Milestone 13 speaks to the extent to which the practice follows up via phone, in-person visit, or electronic means with patients within a designated time interval, whether that's 1 day, 2 days, or 3 days after an ER visit or discharge from a hospital. That's consistent with what many hospitals are trying to do in terms of preventing readmissions, and that's a milestone that should be relatively easy for primary care practices to put in place and work closely with their local hospitals to do so. Milestone 14, the extent to which the practice defines care coordination roles and responsibilities within the practice and have implemented those within the practice. So for milestone 12 specifically, again, the extent to which the practice has identified a medical neighborhood. If we could jump to the next slide. A score of a 0 would indicate that the practice has not identified its medical neighborhood. That is to say, the practice really just hasn't sat down and made a list of all the other physician groups, practices that you're going to work with that exist within your market that address all the specialties that you would work with. And a score of a 3 would indicate that the practice has identified and reached out to the members of its neighborhood who are regularly involved in the care of the practice's patients and has put a process in place for how you're going to work with and communicate with those practices. So if you're a primary care practice, for example, and you've identified, cardiologists that you're going to work with, neurologists, ophthalmologists, GIs, and all of those different providers across the specialties, that's what would satisfy a score of a 3 for milestone 12. And again, a score of a 3 is what a practice would need to complete phase 4. Let's take a look on the next slide at some of the interventions that are listed in the change package to help address milestone 12. So 1, just define the medical neighborhood within which the practice works most closely. That again is going to be the other practices within your geographic area and the specialties that your practice touches the most or needs to work with the most, including behavioral health. 2, develop personal and electronic relationships among medical neighborhood providers. This typically happens in an ACO or a CIN type of environment, but if you realize that you and other practices within your neighborhood are on the same EMR, you can establish communication relationships that way. You can develop processes for how you're going to call, fax, and send information to and from each other when you see each other's patients. So 3, develop formal written agreements. Again, that typically happens in a CIN or an ACO, but that is something, again, 2 practices can agree to do together. Formalize the lines of communication. And that, again, is to make sure that both sides are clear who is going to communicate what and when, with respect from practice to practice communication, and who is going to communicate what to the patients when. Both of those are important. Point 5, ensure that useful information is shared with the patients and the families at every care transition. And 6, engage the payer disease management and complex care management staff to avoid patient family confusion. So if you have care coordination function in your office, or if that falls to the nurse, or if that falls to a population health person, those agents can help to communicate with the patients as well. So again, when we are talking about these milestones and asking what is it that we need to achieve a score of a 3, we're not asking that the practices take all of these items in the change package and implement them all, but we're looking for evidence of progress along these lines, and we're looking for clear evidence that 2 or 3 or more of these things are being done in the practice routinely. Milestone 13. Speaks to the extent to which the practice follows up via phone, inpatient visit, or via electronic means with the patient after a hospital admission through the ER, or once the patient is discharged from the hospital. So a score of a 0 indicates that the practice does not regularly receive information from hospitals about discharges and is not regularly following up with the patients after an ER visit or discharge. And that's typically when a physician or a practice has not yet established a relationship with the hospital, which is very easy to do. A score of a 3 would indicate that the practice has implemented and refined its plan, and it's consistently following up with patients within a designated time interval after an ER visit. And again, a score of a 1 would indicate that the practice is starting to work on a plan. A score of a 2 would indicate that the practice has put a plan, just recently put a plan in place, and is working on standardizing and refining that plan within the practice. So let's take a look on the next slide at some of the interventions that are mentioned to address milestone 13 for primary care practices. Number 1, assign responsibility for care management of individuals at high risk for an ER visit or after a hospital discharge. 2, develop a process to follow up after every hospital discharge or ER visit with a phone call, home office, or 7 days. Most offices have a process in place where they like to see the patient in the practice within 7 days after discharge. If you don't have a consistent process like that in place, then that's something you want to sit down with your care team, talk about, work with the hospital. Again, the quality lead in the hospital or the director of the ED would be more than happy to talk to any practice about how are we going to have a proper transition of care for this patient after they leave the hospital. Point number 3, assure the patients can get access to their care team when they need it to support reduction in ER use. So again, that's 24/7 access, whether that's via phone, email, or other processes that the practice has in place so that the patients can reach them after hours to reduce a potential ER visit. Point 4, partner with community or hospital-based transitional care services. Again, that could be housed within the inpatient team, the quality team, or sometimes the ED has a specific transitional care team, including physicians and nursing and pharmacy. It's important to get in touch with those departments, understand their processes for how they like to transfer care and responsibilities to the practices, and work with them to see how those processes can work best for the patient. Next, establish a routine and timely process for when the patient is hospitalized. How are we going to get in touch with them and the family? When are we going to see them? How are we going to see them? How are we going to work with the hospitalist so that we know what's happening to our patients when they're in the hospital setting? Next, establish a process for how we're going to communicate and work with the hospital and patients after ED visits. And last, encourage patients to rely on multiple team members of experts. So not just the physician, but the nurse and other folks in the office can be seen as experts to help guide the patient in their care. And finally, milestone 14, the extent to which the practice clearly defines care coordination roles and responsibilities and has implemented these practices within the practice. A score of a 0 would indicate that the practice has not developed its approach to providing care coordination for its patient population. This might be typical in a newly established practice where you're still bringing on staff and just haven't had time to talk about this in detail as yet. A score of a 3 would indicate that the practice has a vision for care coordination and is fully documented and fully implemented. And this is typical in many primary care practices where the physician knows the outcomes they would like to achieve. They know the goals that they're trying to reach. They've, in their hiring and staffing decisions, they've brought on staff that agree with that vision or buy into it and can help support it. And they talk about this regularly. They've embedded the different components of that vision within their care processes, documentation processes, and basically that sets the tone for how the practice operates. If we take a look at some of the items in the change package that are mentioned on the next slide, they include developing compacts or agreements between primary care and specialists. Again, just being clear on who's going to do what and when for the patient, and how are we going to communicate back and forth as clinical peers. To assign responsibilities to specific staff members for care coordination and referral management, both on the practice to practice side and on the practice to hospital side. Within that, establish systems for two-way exchange of information within the medical neighborhood. We've touched on that. Follow up on all referrals to ensure that we close the loop on information. Participate in health information exchanges if possible, and use structured referral notes to standardize information shared and facilitate appropriate referrals. And that's really important for primary care physicians when you're working with a number of specialists for very complex patients. When you have a standardized way for how you share information, that will help the information be received in a more consistent way from the multiple specialists that you may be working with. And then additional items, again, establish care coordination agreements with the consultants that you work with most frequently. Track your patients through, track your patients within the referral, within the different specialties that you refer to, and follow them to the best of your ability through the entire process, and at least work with those specialists to make sure that there's a process in place for them to close the loop with you, the primary care practice. Integrate information from referrals into the plan of care. Fourth, allow the primary care team to request urgent appointments for specialist consultants. So that relationship, especially if the hospital is is working with the hospitalists or different specialists in the inpatient setting, having that process in place for the primary care to get in touch with them quickly will help make things go more smoothly for the patient. Have a shared care plan for co-managed patients. Establish a mutual understanding of the information that should be shared when care is transferred or shared among providers. So that typically comes once you've talked to the specialists understand the information that they want and need. You've shared with them most critical information that needs to be shared with the primary care. That will help that mutual understanding of information that needs to be shared go much more smoothly. And last, in the specialty practices for each referral, notify the care team of the date of the scheduled appointments, as well of any cancellations and no-shows. That will help you get on track of any potential gaps in care, and the practice can address that within their given guidelines or protocols. And with that, are there any questions? All right. With that, the seventh class, the class that will be offered next week, will be focused around person and family-centered care. The milestones that we will address for specialty practices include milestones 4, 5, 12, and 17. And the milestones for primary care practices, we have 6 of them, will include number 4, 5, 7, 15, 17, and 22. Again, thank you for taking the time to join this call this morning, and we look forward to seeing you on next week's call.
Thank you, Ivan.